are the same. So sometimes in the exam people ask, what is a relapsed clubfoot or what's a recurrent clubfoot? They are the same words, they're just English terminology. It just means the same thing basically. So anytime there is a recurrence of the deformity or one or more of the different aspects of the deformity comes back, that's called a relapse or a recurrence. Now the reason why the Ponseti method did not become popular, because when Matthew spoke to you about the Ponseti method, he told you the first publication that came out was in 1963. And this was 15 years work of Ponseti already. Ponseti began doing this technique somewhere around the 1940s. And his first publication in 𝐤𝐵𝐺𝐸s, there were two publications back to back. One was on metatarsus adductus and one was on his method of correcting of clubfoot. And whereas the metatarsus paper was accepted very easily by the orthopedic community, everyone who read the clubfoot paper completely ignored it. So you'll be surprised that in 1963, the same thing we're following today, that paper was rejected by the orthopedic community. And anyone knows the reason why. I don't expect that you all have read that paper, but if you haven't, you all should go back and read it. There are these few publications that if you all are doing the Ponseti method, you must read. One of them is this 1963 publication, one of them is the 1980 publication, one is the 1996 publication, all of them in 𝐤𝐵𝐺𝐸s. The 1996 publication is the most important one because that showed a 34-year follow-up of the Ponseti method of the minimum age was 34 years of follow-up. So going back to the 1963 publication, what happened in that publication was that the relapse rate that Ponseti described of his own technique devised by him was, anyone knows? What is the relapse rate or recurrence rate that Ponseti described? As high as 52%. That means if you have done the Ponseti technique and by the man who devised the technique, half of those children will come back with a recurrence. So will you adopt such a method? Suppose I tell you that you've got a fracture of the shaft of the femur and I'm putting a nail in it and there's 50% chance of non-union. Will you accept that method? You will not. So this is exactly what happened to the Ponseti method. That though he published his results honestly, see anyone else would have probably fibbed those results and said, oh, I've got 10% relapse rate. But he was honest with each and every patient that he followed up and said, in 15 years that I've been using this technique, when I published in 1963, I have a 95% or maybe more, 98% success rate, but a 52% relapse rate. Now who will accept that? Okay? But he was convinced by his technique, he was convinced that what he was doing was right. He knew he was on the right footing because he saw the correction. He saw that 98% correction. Why was it relapsing? And he started working over the next few years to find out why that relapse was occurring. Why were 52% of my patients coming back with a recurrence? And he found that there were two main reasons. Okay? The first reason that he found out was he was not giving enough abduction in that last plaster. That's why today if you've heard our talks, you've seen the demonstration as well. You've seen that we have always insisting that before you do the tenotomy, you have at least 50 degrees of foot abduction. And after you've done the tenotomy, you should get 70 degrees of foot abduction. So you should get more abduction after you've done the tenotomy, which happens and it makes sense because as you get dorsiflexion, you also get eversion and abduction. So Ponseti did not follow that initially. He was giving like around 30 degrees of abduction. And therefore, within the first 3 months, 6 months, 1 year, the foot would turn back again. Until he cracked the code that the important thing to prevent a relapse or recurrence in those first few months or first few years is to get that full abduction of 50 degrees before the tenotomy and 70 degrees after the end of the tenotomy. And that will prevent the foot from turning back in. The second thing he understood was if you want to prevent relapse and bring it down to a manageable level, you have to use what Matthew just spoke about, which is the foot abduction brace. Everyone is sleepy, I think time for tea. Yeah? So don't forget that the foot abduction brace, why is Matthew spent so much time talking about it? Because that is the one thing which decreases the risk of relapse. So if you want to prevent relapse in your patients, and now over the years we have found that if you do the Ponseti technique well, you can enjoy that same success that Ponseti developed, which was 98% success rates. And you can bring your relapse rate or recurrence rates down from 50% to 15%. So the latest literature that we have tells us that if you follow the Ponseti method well enough, if you do the right correction, the right manipulation, and then you ensure that you get the full abduction in that last plaster and maintain the child in a foot abduction brace for at least 4 to 5 years, the relapse rate can come down from 50% to 15%. And that's what we should all be aiming for. So if you, in your practice, as you do more and more Ponseti plasters, if you see a significant number of patients coming back with a lot of relapse, you know that you're not doing one of these two things, or you're not doing both of them. You're not ensuring the full abduction of the foot to 70 degrees, or you're not ensuring that the child is compliant and adhering to the brace protocol. The The more common one is the brace protocol because parents often don't use the braces. Okay? So you have to ensure these two things. So that's how you can bring down your relapse rate. How do you diagnose a relapse? It is just by observing the child, or the parents come and tell you that it was corrected well before and now some or all the deformity is coming back. And the deformity can come back completely or it can come back only partially. Maybe only the cavus returns, maybe only the equinus comes back, maybe only the varus returns back. Once you have diagnosed a relapse, what should you do? Anyone? Start the Ponseti method. So that's not the time to bury our head in the sand. Because we as surgeons are sometimes, we look at these as failures. But if you understood that Ponseti himself had a 50% relapse rate, we should understand that this is not a failure. This is a part of the technique, that relapses are bound to happen. So by sitting on it, it's not going to work. The minute we diagnose a relapse, we should tell the parents, back again to casting, if required, once more tenotomy, and then reinstitute the bracing protocol all over again. Reinforce the importance of that bracing protocol, because more often than not, it is the lack of the bracing which is causing the foot to relapse. So get them to understand, and that's where the counselors have a big role to play. The biggest advantage of our program over the last 10 years we have seen is that the way to bring down the relapse rate is by having the counselors talk to the parents, because we don't have the time in a busy clinic to go do the plasters, do the tenotomy, and then sit and counsel the parents about the importance of bracing. But that's where the counselors have a very important role to play. They have that rapport with the parents and the family to make them understand that if you want the relapse rate to be less, it's in the hands of the parents to ensure that they use the brace as Matthew has described. For the first 3 months, 24 hours, and then decrease it down till you have a nights and naps protocol. All right? So this is how you manage a relapse for the Ponseti method. There's another entity which we have to talk about also. So this is all about early relapses, which generally happens in the first 1 year of the first 2 years. As the child starts walking, there's another type of relapse that can come in, despite the fact that the parents are using the brace, despite the fact that you have done a good job, and that is what's called a dynamic supination. So you have some children who, when they start walking by the age of around, so they start walking by 1.5 years. By the age of 3 or 4, you'll find that when you look at the feet, when they're sitting, the feet look very nice. But the minute they start standing and walking in the swing phase, the foot starts turning in. And when they land on the foot in the loading response, the foot weight bears on the lateral border of the foot. But again, when the foot is off the ground and you look at the foot when the child is lying, the foot looks perfectly nice. So there is no static recurrence. The foot looks well corrected. But there's a dynamic recurrence because of the imbalance between the inverters and the everters. And that's a very easy problem to solve, because when you have this imbalance that exists in clubfoot, when you have the inverters, which is the tibialis anterior, stronger than the peronei, we know that that will cause a dynamic supination of the foot. Okay? Some of these children will have a combination of static and dynamic. So be very careful that when you assess a child who has a dynamic supination, be sure that there's no static component to it as well. So always examine the child in the supine position, check if there's a static component as well, because if the dynamic supination lasts long enough, it can also undergo a static relapse. So if you find that the Pirani score, how do you diagnose a static relapse? The Pirani score starts going up. Okay? In a dynamic supination, the Pirani score will remain static, because really the foot is well corrected. It's just there's an imbalance between the inverters and everters, which is causing the foot to turn in during the swing phase and in loading response. But otherwise, the foot is otherwise well corrected. But if your Pirani score starts going up, it was before 0 or 0.5 and now starts going up to 1 or 2, you know that there is a static component to the dynamic relapse as well. So then you have to manage it differently. Then you have to first correct the static deformity, which is by going back to plasters or doing the tenotomy, and then do the tendon transfer for the dynamic supination. How to correct a dynamic supination? It's a very simple procedure. We do what is called a tibialis anterior tendon transfer. So the tibialis anterior, which is inserted into the base of the first metatarsal and the base of the first cuneiform, we take it out from the insertion and transpose it to the third cuneiform, which is the lateral cuneiform, which is in line with the third metatarsal, which is the axis of the foot. So it's a very simple procedure, very easy to do. You make a small incision over the medial side, disinsert the tendon from its insertion on the medial cuneiform, then make a tunnel on the lateral side and reinsert it into a hole in the bone, which is made in the lateral cuneiform. And then once you have done that, you put the patient on a plaster for around 4 to 6 weeks, remove the plaster, and the child can start walking. And what you have done basically is you have centralized the pull of the tendons. You have now balanced the foot, because this imbalance between the inverters and everters has now been stabilized, because you have moved the strong inverter to the center of the foot and made it into a pure dorsiflexor. So this is how you diagnose and this is how you manage your relapse, either which is static or which is dynamic. Depends on whether the child has come to you with an early relapse or a late relapse. Okay? Clear? Any questions? I've not used any slides here because I think this covers most of the talk. Okay? Good.
After how many casts we can say is a resistant setting?
So that's a good question. I don't think it's the number of the plasters because there's no mathematics in this. It is where the Pirani score helps. So if you find that you're convinced you're doing a right plaster, if you feel that you've done the proper technique and the Pirani score is not improving at all, that means it's remaining static for many, many times. So you've done your 4th plaster, 5th, 6th, 7th, 8th, the Pirani score is remaining the same or not decreasing enough. That is the time, I think the first step is before you call it resistant, show it to a senior. It's always good. Because it may be that there's a problem, which is most likely that there's a problem with your technique, either in manipulation or in casting. That's the first and most common reason why we call a foot resistant. So always take it up to the next level. If it was me doing it, I would go to Matthew because I know he's more senior to me and he does a better casting than me. So I would go to Matthew and say, Matthew, I'm having a problem with this foot. It's not responding. I've given 15 plasters. What should be done next? But please don't go into a stage where you're giving the patient 15 and 20 and 30 plasters because it only causes more harm. So giving more plasters is not the answer for a resistant foot. Okay? So if you're crossing more than 8 or 10 plasters in a young child, now remember I'm talking of a child less than 1. As you talk an older child, then obviously you need more and more plasters because the foot is more and more stiff and more rigid. But in a child who's less than 1, the counselors, I don't know whether Santosh is still doing that, have been told to red flag any child whose casts go more than 8. So if you cross more than 8 plasters, the counselor is supposed to red flag it and take it to the next level of seniors and say that the number of casts is going above 8, something is going wrong. Okay? And when your senior assesses it and still feels that it's possible to correct, then the senior should take over and start doing the casting the right way. But only if that person also can't get the correction and the Pirani score still remains static, then you know there's a problem with the foot. So before we blame the foot, we should blame ourselves first. Take onus on ourselves that maybe we're not doing the right manipulation, maybe we're not doing the right cast. If we are sure that we have done the right job, then we can blame the foot. And we know that children who have syndromes, children who have severe arthrogryposis, children who have 𝐬𝐨𝐜𝐢𝐚 are the ones who are like to develop a resistant foot. So the minute you see a secondary clubfoot in the beginning itself, you can predict that there is a chance that this child will not respond to the Ponseti method. Remember, we should never be people who believe in all or none because you're going to be wrong. When we say that it works, we say it works in the majority of cases. Okay? So can I say honestly over the last 20 years I have not done surgery in clubfoot? No, that's dishonest because I know that the Ponseti method works in 90 to 95% of children. But that means there are 5 to 3% of children who will need surgery. And especially if you have a syndromic foot, if you have a secondary foot, if you have an older child, these children will need some form of surgery. So surgeries are not out yet. And anyone who comes and tells you that for 20 years, 100% of my patients are treated by the Ponseti method, I think you should disbelieve that person. Okay? So you will find a certain number of patients who will need surgery, and especially the ones who need it are the syndromic, secondary, neuropathic, arthrogrypotic, 𝐬𝐴 older children.